Hello, this is SkyCushion9, and welcome to Transsistance, a series of videos that talks about many of the topics involved with transitioning, from the point of view of a future medical student and a male-to-female transsexual. Over the course of these videos, I will help describe the physical, medical, and other aspects about transition, ranging from the anatomy involved, to hormone replacement therapy, to the various surgeries. I hope that with this series of videos I can help educate both transsexuals who are considering transitioning, as well as those who would like to just better educate themselves about an important event and undertaking in the transsexual world. With that, let's get started. One of the advantages that a female-to-male has over a male-to-female when transitioning is that a female-to-male has less surgeries to do in order to better pass physically. Female-to-males have no analogous surgery to either the facial feminization surgery nor the laryngoplasty. With the former, while a masculine skull shape can be offsetting for those who present as female, a feminine skull shape is not something that can be out of the ordinary for female-to-males or anyone presenting male. While a person might get a crack about looking girly, many people gloss over men lacking masculine features in their face, and even if a female-to-male wanted a more masculine face, the technology to perform the opposite of a facial feminization surgery, otherwise known as a facial masculinization surgery, is either lacking or not in existence, likely due to a lack of need. As for the later, a female-to-male on hormone replacement therapy will have their vocal cords thicken naturally as a result of exposure to large amounts of testosterone, and will eventually develop a voice indistinguishable from that of a genetic male. However, there are still some surgeries to discuss, one in particular that many FTMs get. Surgery number 1. Mastectomy. Out of all the surgeries for female-to-males, this is likely the most commonly done one, as it addresses the one item of a female-to-male's body that needs to be altered in order to hope to pass as a male, especially when not wearing shirts. The purpose of a mastectomy is simple: removal of the breast tissue, which is primarily in the form of the mammary glands and ducts, as well as the general connective tissue. However, the size of a female-to-male's breast can alter how the procedure is performed. If the patient has a larger cup size, think C cup and up, a female-to-male will undergo a bilateral mastectomy. In this version of the procedure, incisions are made horizontally across the breast just below the areolas, and the breast tissue and excess fat are directly removed from the incisions and are sealed up. This procedure is favored for larger breast cups, as the alternative method would not be effective. Bilateral mastectomies tend to produce a more male-looking chest. However, for those with smaller breasts, a major downside to note involves a large risk of loss of sensation to the nipple, and the bilateral incisions can easily cause damage to the nerves in the breast. This procedure also tends to require longer recovery times. If a patient has a small cup size, think about A and B cup, then a keyhole or periareolar incision is offered as an alternative. Most involve making a smaller incision around the areola, and then have the advantage of being able to preserve the nipple and the nerves connecting to it, but both have slightly different ways of completing the procedure. With the keyhole procedure, a small incision is made along the bottom edge of the areola, then the breast tissue is removed via a liposuction needle. With the periareolar procedure, however, an incision is made completely around the areola, and the breast tissue is removed manually via a scalpel or liposuction needle. The downside with this avenue is that excess skin is not considered an issue and is not removed like it is normally with bilateral mastectomies. Therefore, it is possible for the chest to not fully be flat and can sag a bit. Regardless, either procedure carries the usual risks associated with surgery: blood clots, loss, etc., and a binder is usually worn 1 to 3 weeks after the surgery to aid in healing. Tubing will also be left in the incisions of the breasts to collect excess fluid and blood for some time to prevent pooling under the tissue. Both procedures are relatively quick, around 4 hours, and recovery can be outpatient, so possibly no hospital time. Surgery number 2 and 3. Hysterectomy and bilateral salpingo-oophorectomy. Like with the orchiectomy for male-to-females, female-to-males have the option of essentially disabling their reproductive system without going through sexual reassignment surgery. Hysterectomies, which involve the removal of the uterus, have some of the same advantages as the orchiectomy. They're cheaper, involve less recovery time, and have the procedure done allows patients to lower the dosage of their hormones without detriment. However, there are 2 other good reasons for a female-to-male to undergo this surgery. First is that a transitioning female to male can experience embarrassment and conflicts when trying to access OBGYN care, such as pap smears, so the removal of the uterus means that this will no longer be a concern. The second benefit, however, is a more serious one, and a possible reason why a number of female males are able to have this surgery insured, which is considered a rarity in the transsexual world. While the relationship between long-term androgen use and gynecological health is still in question, concerns have been raised that prolonged testosterone usage can lead to symptoms similar to polycystic ovarian syndrome, or PCOS. A reason for this is that a female-to-male's hormone regimen can eventually weaken and shut down the ability for the body to have a period, which means the endometrial tissue of the uterus builds up instead of being sloughed off by the body. And buildup of endometrial tissue can lead to various kinds of uterine cancer. Therefore, in some ways, a female-to-male can classify this as a preventative measure, especially if the patient's family has a history of uterine cancer. With hysterectomies, there are multiple different ways a surgeon can proceed with removing the uterus, mainly differing in locations of incisions. The 4 types of procedures are as follows. First, total abdominal. Incisions are made in the abdominal wall, and the uterus and cervix are cut away from the ligaments while the internal end of the vagina is sealed. This is the most invasive of the techniques, therefore it leads to longer recovery times, and is generally not recommended nowadays. Second, total vaginal. Incisions are made through the vagina instead of the abdominal wall. This technique can be problematic because 1. A lack of access to the abdominal cavity can hamper a surgeon's ability to easily remove the cervix, as well as check for endometriosis, a condition where cells in the uterine lining grow in other areas of the body. And for 2, this can only be feasible if the patient has great vaginal flexibility and no adhesions in the body. However, it does have a shorter recovery time than the previous method. 3. Laparoscopically assisted vaginal. A total vaginal hysterectomy, only assisted with a laparoscope. Small incisions are made in the abdominal wall in order to allow a laparoscope, a special medical camera, into the body, which allows the surgeon to observe from the abdomen, which addresses the major flaw with the total vaginal hysterectomy. Recovery time is slightly improved from TVH, however those with restricted vaginal canals are unable to have this done, and the final technique is recommended as an alternative. Speaking of which, technique number 4, total laparoscopic. Small incisions are made in the abdominal wall, and the cervix and uterus are removed from it or passed through the vagina. TLH repeats the usage of a laparoscope like from LAVH, however the vagina in this case is not harmed. Because no major incisions are made in the vagina, TLH has the best recovery time out of all options and is the safest option out of those listed. The downside is that TLH is still a relatively new technique, therefore not very many surgeons will be experienced in performing it. Alongside a hysterectomy, surgeons also typically perform a bilateral salpingo-oophorectomy, or BSO, which is simply the removal of both of the ovaries, as well as the fallopian tubes. These are typically removed both as a way to limit the body's female-level production of estrogen, and as a preventative measure for ovarian cancer, which can develop due to lack of use over time. Unfortunately, hysterectomies share similar downsides with orchiectomies in that they can negatively affect aspects of SRS in that it can limit the amount of skin tissue that can be utilized. However, unlike the male-to-female side, having a hysterectomy prior to SRS can actually make the procedure cheaper. A reason why female-to-males have this discount while the orchiectomy typically has no effect or negative effect on the price of SRS for male-to-females may be simply because of the size of the tissue involved, as the uterus can easily eclipse the size of both testicles alone. In either case, having a hysterectomy done prior shortens the time SRS is performed and can help with recovery time. Only a discussion with your surgeon can really tell someone whether hysterectomy should or could be done before SRS or not. And with that, I've come to the end of the discussion for secondary surgeries. So, this is Guy Christian 9, this has been Transsistance, and only one topic remains for this series, the sexual reassignment surgery. I'll see you then.